So we are continuing on chapter 16, postpartum emotional assessment. Let's get with it.
Okay, let's talk about emotional status assessment in the postpartum period. If a postpartum patient has struggled with depression or anxiety in the past or during their pregnancy, then the risk for postpartum depression is going to be much higher, and they should be monitored and a little bit more closely. The things that we're going to look at as we assess for the emotional status would be interactions with family. What kind of family support do they have? Do they have family drama? And let me tell you, you're going to see family drama in labor and delivery, right? So it's all there, and it just seems to be that this kind of event seems to just invite some family drama. So if they do have family in town, is their family supportive or involved? Some patients don't have family here. Even their partner is out of town, right? In military or some situations they have to work. They don't get time off of work. And so it's just, there's lots of different levels of support and what is considered family and what's not, right? But we just want to make sure that they have a good, positive support system to help them. The patient's level of independence. It's important to identify the level of independence in the patient, just to get a baseline of how much teaching they're going to need in the short time that they're in the hospital. So how comfortable are they with a newborn or with a baby or with baby care? Energy levels. One sign of postpartum depression is just depleted energy and exhaustion. This can be difficult to determine when they're hospital because it's just an exhausting time and their bodies are still recovering. But it's something that we need to be looking at and talking about, and this will become more prevalent once they're home within a week or two. I always try to give all of my patient education, especially when it comes to postpartum like depression or just emotional status, with someone else at the bedside. It's so hard for any of us to recognize when we're depressed or when we're not. It's just a tricky thing. If we don't feel like killing ourselves or killing our baby, then we think we might be fine. But there is a lot of postpartum anxiety that goes on also. And so these are just some things that we need to assess. It's nice to have another set of eyes on this person when they go home to kind of gauge how things are going. Eye contact with the baby. Are they bonding with the infant, or do they not seem interested? Are they letting other people take care of the baby? Posture and comfort level with the infant. So there have been times when I've had people who are literally terrified to hold their child, right? Or to change their diaper or to put them in a blanket. So all of that is just different based on the person. And so these are things that we're assessing. But if they're not really comfortable, they're extra scared, beyond just kind of like I've never done this before, then that's just something, a red flag that we need to look for. Are they getting rest while they're in the hospital? Do they have, they're trying to get some sleep and sleeping, because that's going to affect their mental health. And then we just need to always be alert for mood swings, irritability, or crying episodes. This can be very, very normal. More than once have I had somebody looking at me panic-stricken or tears in their eyes, just completely overwhelmed or don't know what they're doing. And they just need a little bit of encouragement. They just need to know they're doing a great job, and this, baby was meant to come to them, and that they're going to be fine. So you usually just need a little bit of encouragement. If we're going and swinging on the other end of the pendulum, when they're even more, it's just more excessive, the crying or the mood swings or the irritability, then that's just some things that we need to look for. It's a normal finding unless it starts to get it to be extreme. So a postpartum depression takes a lot of adjustment when we have a baby and we go into postpartum. So things that we're going to assess for would be apathy, apathy to the appearance and the interactions with the newborn, disinterested in infant care and communication with family members, no appetite, uninterested in the environment and the activities that surround the newborn, if they're sad and if they're tearful. These can just be some signs of baby blues or postpartum depression. When we go into psychosis, we talked about that in the last chapter, but it gets to be a little bit more extreme, or a lot more extreme. They have confusion orientation is altered. They'll have hallucinations, they have paranoia, and they just have extreme emotions. So it's a little bit different. I shouldn't say a little bit, it's a lot different than a depression, right? This gets into the ones that you hear about, that they tried to drown their babies, or they drove off into a lake with their car, with their kids in the car. So this would be a psychosis and is much more extreme. We also want to be looking for bonding and attachment. So bonding, is close emotional attraction to the newborn by the parents. It usually develops in that first 30 to 60 minutes after birth. This is why skin to skin is so important, because it enhances that bonding experience. When the infant demonstrates feeding cues or makes noises communicating with the parents, this helps the parents bond with the baby, right? They reciprocate that. They go, oh my gosh, they're doing this and this and this, and it's all so cute. Everything's just adorable, right, in that first little time. It is usually unidirectional from parent to infant. Infants can't give a whole lot, especially during those first few hours, but really the first few months they can't give too much. But anything they do give is usually met with an over-exuberant excitement of just how cute it all is. Bonding is a really important time. Honestly, I try not to interrupt this very much. I let the parents do that. If they invite me in and they ask me questions and they want me to be present, then I will offer my education and advice, things like that. But typically I let them just to be a really special time with mom and baby. Do I still do my my fundal assessments? Yes. Do I still assess the baby? Yes. I just try to do it quickly. I cluster all my things together so I can do them quickly and get out quickly. I'm not avoiding the room. I'm very present in the room. I'm also not interrupting and injecting my thoughts or my anything into it unless I feel like it's needed and I'm invited to do so. So does that make sense? I notice a lot of students avoid the room because they feel uncomfortable because it's such a special time for the baby, but we have an important, very important role in that first hour or two after delivery to assess and make sure that everything is healthy and happy. And I'll tell you my stories about this in class, but we don't want to avoid the room, but we also don't want to overexert ourselves either, right? So we're very present, but we're just letting them do them and create their own experience during that time. Attachment is more of a longer term thing. It's a strong affection between infant and a significant other, meaning the mother, father, sibling, caregiver. Infants, automatically attach to those significant people, and they just bond over time.
Okay. Nurses working as part of a committee to establish policies to promote bonding and attachment. Which practice would be least effective in achieving this goal? Allowing unlimited visiting hours on maternity unit. Offering around-the-clock nursery care for the infants. Yeah, that would be it. And that's correct, because you want them to be taking care of the baby.
So bonding and attachment as we transition into parenthood. The transition to parenthood can be hard. It's the most rewarding thing you're ever going to experience in your life, but equally it is the hardest thing that you will ever experience in your life, in my opinion. So to me, it's just the biggest dichotomy. I've experienced both, right? The highest of highs and the lowest of lows, being a parent, and transitioning into parenthood was tricky. So the transition factors that affect the attachment would be the parent's background, their comfort level with infants, their support system, if they work. So it's just a major life stressor, right? And so when identifying the right time or if you go back to work, daycare arrangements, gender relations and gender roles, everything kind of comes to fruition and what you believe on that. So it takes a minute to transition there. The critical attributes of attachment, the first one that they list in your book would be proximity. So this is definitely going to influence attachment, right? So ideally, we are there immediately. The parents are able to touch and love and be close to that infant. If the infant goes to NICU, then we could have some issues with attachment and bonding. Not always, and the majority of NICU babies bond with their families just fine, but it is a risk factor. For proximity, there's 3 different dimensions that your book talks about. Contact, that's the holding, gazing, looking at the baby, touching the baby. It's a sensory experience. Emotional state, that emerges from the affective experience of the new parent toward the infant and their new role. And then individualization is when the parents are aware of the need to differentiate the infant's needs from themselves and to recognize and respond to the infant appropriately, typically over their needs. Reciprocity is the process in which the infant's abilities and behaviors elicit a parental response. So, right, it's reciprocal. So the baby sticks their tongue out, the baby looks and gazes at mom, it's reciprocal, right? So they'll give back. I remember I had a baby who just cried. And then the second she was put into my arms, she stopped crying and just gazed in my eyes. And so there was a huge attachment there, right? Like I'll still get all happy about it because it was just like, this beautiful attachment with the mom and the baby. So that's that kind of reciprocal. It's easy when something like that happens. When it doesn't happen and the baby keeps crying, even though mom's holding it, you start to get full of self-doubt and you're like, oh my gosh, I thought this was just supposed to happen. So sometimes we have to promote that bonding and that attachment. The last one is commitment. And so this is just kind of the enduring nature of the relationship, you would think. Anyways, we'll talk about this more in class. But the components of this are twofold, including centrality and patient role exploration. One thing that surprised me when I entered into parenthood is how many people have an opinion on how you should do it. And I mean complete strangers at the grocery store, to the park, to friends and family. I went from a confident young professional to pretty much an insecure mess. So it took me a minute to figure out my role and how I was going to parent, to throw away the books and to kind of trust my instincts for me and for my child. But it takes a commitment, a level of commitment to say this is what I'm going to do and this is how I'm going to do it. And it will change down the road, but that's how it is. Then your book has this table of positive and negative attachment behaviors. So just some things that are positive, which be like in the infant would be a smile, that they're looking, that they suck well, they're easy to be with, they have a good temperament. For the parent, positive attachments would be making eye contact, letting the baby see the parent's face, just expressing pride in that baby. And then the negative for the infant would be poor feeding, long cries, inconsolable, doesn't make eye contact, body stiffens when you're holding them. Those are really hard behaviors, for new parents who want to attach to their babies. And then for the parent, we've talked about these, but express disappointment or displeasure. They avoid caring for the baby. They find excuses. They let other people do it. Those would be negative attachments. And factors that influence attachment would be parents' background, again, their culture, how they were raised, how familiar they are with caring for infants, the infant's personality or temperament or health at birth, if the baby's medically fragile or has just a colicky, cryy temperament, that can be hard. Care practices, that's just kind of the same as background, but how familiar they are with caring for a baby. If there's separation immediately after birth, if that baby goes to NICU, is on a ventilator and they're not really able to touch the baby or hold the baby or bond with the baby, that can influence attachment. Policies discouraging exploring the infant. So sometimes in the hospital, they're on low stimulus, like in the NICU, right? They're not allowed to touch or handle their baby. During COVID, we weren't really allowing anybody in. Some women had to deliver by themselves. And so that would affect attachment to the caregiver and maybe even to the wife or to the person delivering the baby. Intensive care, we talked about that, how sometimes if they have to go to NICU, and then staffing indifference or lack of support. So this is something we definitely have control over. We really still are a big part of the team, even though you might feel uncomfortable, like this is their experience. People want their nurse to be actively involved and to be present and to be helpful and teaching and showing things. So it's important that we provide care, that we don't judge the situations, and that we treat all patients with dignity and respect, and just encourage a positive outcome or a positive attachment and positive outcome for the family.
Right, we are done with that.